So I'm going to talk about introduction to chemotherapy today. The chemotherapy first was discovered in 1950s and 60s. Prior to this period, the surgery was the only treatment of choice. And this is also the time when radiotherapy came into view, the orthovoltage X-ray and nuclear medicine. Madame Curie's results also introduced. So 50s and 60s is the time when the management of cancer took a sea change and newer therapeutic strategies like chemotherapy were included. Now, uh, after the introduction, it was seen that chemotherapy is able to cure cancer, and people thought that if this can be integrated into the treatment algorithm with surgery and radiation, and if we use the all the three modalities together, we probably will be able to get a better response, better cancer control than using one of the modalities alone. And this also led to evolution of uh, multimodality treatment over a period of time. So whatever change has occurred in cancer therapy has occurred in last 50 or 60 years. Now the biggest problem with chemotherapy is the toxicity, because most of the chemotherapeutic agents which we use are not able to differentiate a normal cell from a abnormal cell, and they basically kill every cell which is dividing. So there is a lot of toxicity. And the second problem that occurs is because of increase in the drug resistance. When a drug is used for a longer period of time, the cells become resistant to that drug, and then there will be no more cell killing. So it is important to know what are the mechanisms, or what are the mechanisms through which these drugs act, and use them in a better manner to exert the cytotoxic effect. It was Paul Ehrlich who coined the term chemotherapy. So now if you look at the history of chemotherapy, what has gone beyond? If you look at the history of chemotherapy, now this chemotherapy actually has been discovered accidentally. During the World War I and World War II, people were working on various gases, and one of the gas which was used was nitrogen mustard. And it was seen that when the people were exposed to nitrogen mustard, they had a suppression of bone marrow and they had lymphoid hypoplasia. So this led scientists think that if a gas is suppressing the bone marrow and is causing lymphoid hypoplasia, then this can be used for the treatment of blood cancers. And that's how in 1943, when the First World War was ending, nitrogen mustards were used for hematological malignancies in 1943. Bernard Fisher is a man who is known as father of chemotherapy because he has done maximum work with the NSABP in getting the chemotherapy included in the normal management of cancer patients. Now, how these are used? So chemotherapy is used as a primary treatment. Like I said, lymphoma, leukemia, or other blood cancers, where surgery and radiation are not effective, chemotherapy is the primary modality of treatment. Chemotherapy is also primary modality of treatment when the disease is advanced and surgery is not possible. Chemotherapy is used as induction followed by maintenance. This is done for most of the hematological malignancies. You give a higher dose of drugs, and once the cancer comes under control, you put the patient on a maintenance dose of chemotherapy. Another use which has become very popular nowadays is called as neoadjuvant. This is where the chemotherapy is given before any form of local therapy like surgery or radiation. So you have to understand that the surgery or the radiotherapy are the local form of treatment, while chemotherapy is a systemic form of treatment. It is given through the blood and hence goes to every part of the body. Another application is adjuvant, which is given after the surgery or radiation therapy or both. That means you do the surgery first and then give chemotherapy. There is a concomitant chemoradiation, concomitant with radiation, which is called concomitant chemoradiation. This is used to maximize the result of radiation therapy. The chemotherapy is given along with the radiation. A new use that is now picking up is direct installation into cavities, like you have peritoneal irrigations, IPAC, which is coming into play, and then palliation. When nothing else can be done, you can give some sort of chemotherapy to the patient. As I said, primary induction chemotherapy is given for leukemia, lymphoma, and it is also used for osteosarcoma or bone tumors to make the tumor shrink and limb conservation becoming possible. Neoadjuvant chemotherapy is basically chemotherapy which is given before the surgery. Now, the use of neoadjuvant chemotherapy is something similar to induction chemotherapy, but in the neoadjuvant chemotherapy, what you do is you want to reduce the tumor size and make it amenable to surgery. Like if you have a tumor in the breast, you want a breast conservation, so you give chemotherapy, reduce the size of the tumor, and then go ahead with breast conservation. So neoadjuvant chemotherapy is basically used for organ preservation, and it is also used to reduce the bulk of the tumor and making the tumors operable. So those tumors which are borderline operable or inoperable to begin with may become operable if the chemotherapy is given first. Adjuvant chemotherapy is given after the primary treatment is over. And adjuvant chemotherapy is basically given to reduce the disease recurrences, whether locally or systemically, and it basically improves the overall survival of the patient. So neoadjuvant chemotherapy, most of the instances does not improve the survival, but adjuvant chemotherapy, most of the instances improves survival. Now, whenever the chemotherapy is given, you have to measure the response of the patient, whether how the patient is responding. And also you have to measure the toxicity of the patient. So to measure the response, a criteria which is used is called RECIST, that is response evaluation criteria in solid tumors. This is a set of rules which defines whether the patient is improving, remains the same, or the patient is not improving with the treatment. And there is a WHO criteria for the drug toxicity, which classifies the toxicity into grade 1, grade 2, and grade 3. As the grade increase, the severity of toxicity increase. The commonest toxicity that you see with the chemotherapy is the bone marrow toxicities. And apart from that, the GI toxicities you see. Other toxicities are very specific to the drugs that are being used, and we will be talking about them when we talk about individual drugs. So as per RECIST, a partial response is defined as a reduction in 30% of the size of the measurable tumor mass. So if you have a 10 centimeter tumor, you have given chemotherapy, tumor becomes 7 centimeter, you call it a partial response. Okay. And if the tumor completely disappears, you call it a complete response. And the patients where the response rate is higher or they have a complete response rate, they do better than those who partially respond to chemotherapy. Stable disease is when there is no change in the size of the lesion. You call it a stable disease. And if there is an increase of more than 20%, you call it a progressive disease. Or if there is a new lesion or a metastasis that appears, again you call it a progressive disease. So if a 10 centimeter tumors become 12 centimeters, you call it progression. Or if there is a metastasis or a new lesion which appears, then also you call it disease progression. So basically, chemotherapy response is divided into 4 categories: partial, complete, stable disease, progressive disease. Now, apart from the chemotherapy response, there is something called as an endpoint, or at the end of the therapy, when you evaluate the patient, what are the things that you look for? As I said, induction chemotherapy for solid tumors and neoadjuvant chemotherapy, you look at the rate of organ preservation. that how many of the organs you were preserved or you had to remove the organ. In metastatic disease, what you look for is or a disease where it is cured, where the chemotherapy is used as the adjuvant. You look at relapse-free survival. That means the amount of time a person who has been treated with chemotherapy remained without a recurrence or a relapse. Overall survival is the time a person lives from the time you start the treatment till his death. Quality of life is one of the major important parameters which are now coming into play, especially if you are not able to cure a patient. So in a patient which are not being cured, you look at quality of life and you try to see to give a good quality of life to the patient so that he can do his activities of daily living without any hindrances, and he is not bedridden and his quality in any way is not compromised. Another parameter which is used mainly for metastatic disease is called as progression-free survival. So this is the uh, time of time interval between the treatment and progression. So in the palliative chemotherapy, the day you start the palliative therapy and if till the day patient progresses, that period is called progression-free survival. But the most important factor in cancer treatment always remains as the overall survival. Okay, let's talk a little bit about cell kinetics and response to chemotherapy. To understand how the chemotherapy kills, you have to understand the cell kinetics. Normally, if you look at the growth kinetic, the commonest area where you would have heard a growth kinetic would be uh, reproduction. From a single cell to a zygote, and then how it progresses to 2, from 2 to 4, 4 to 16, and 16 to 64, which is called as exponential growth. The reverse happens in chemotherapy. When you give the chemotherapy kills a certain number of cells every time it is given. And that cell kill is a logarithmic cell kill, which would mean that suppose if a drug kills the 3 log of cancer cells each time it is given, and you start with 10 to power 10 cells, then at the end of first cycle you will have 10 to power 7 cells. After the second cycle you will have 10 to power 4 cells. So this is called as logarithmic cell kill kinetic. Every time a drug is given, this is not universal for all the drugs, but it is a generalized for the drugs which act independent of the cell cycle. So if a drug is acting independent of cell cycle or acts in all phases of cell cycle, you will usually get a logarithmic cell kinetic. But if it is cell cycle specific, then the cell kill will depend upon number of cells present in that particular phase of the cell cycle. Now the tumors follow what is called as a Gompertzian model. They usually do not follow the exponential or logarithmic models. Now the reason for the Gompertzian model is these are the 3 models here. If you have a exponential model like in blue line, the cell will keep on increasing with time. If you have a logistic model, which is usually a C-shaped or a S-shaped line, where early in the time the number of cells will increase till it reaches a plateau and then it will remain constant over a period of time. But in Gompertzian curve, the growth rate is less than logarithmic or exponential, and it never reaches a plateau. It will always keep on increasing, but the rate of increase will keep on getting slower with the time. Now, this is because as some of the cells are being regenerated, some of the cells die. And the death of cell in tumors is because of hypoxia. Because as the tumor grow larger in size, they need oxygen, they need nutrients, and the supply of nutrient and oxygen keeps on decreasing with time. So the center of the tumor starts getting necrosed. The peripheral tumors will get the nutrition, the central part of the tumor will not get the nutrition, and the central part of the tumor starts getting necrosed. So the number of cells in the center will keep on decreasing, the numbers at the periphery will keep on increasing, and it is the difference of death versus new cells produced will keeps on reducing your growth rate. It is said that the growth fraction peaks when the tumor is approximately 37% of its maximum size. So when the tumor reaches one third, approximately one third of the maximum size it can attain, the growth fraction is highest. As it goes above 37%, growth fraction will keep on reducing. And I already told you that it depends upon where or the which phase or what time the chemotherapy or the treatment is given. So the red line in this graph represents a natural progression. If you do not do any intervention, either a surgery or a radiotherapy or a chemotherapy, the cell will keep on growing till the patient dies or till they die of their own natural death, represented by the red line. Earlier you intervene at the time when the growth rate is higher, better is the survival, because as the growth rate is higher, the cell kill will be higher. And later if you intervene, the cell kill will be lesser. So that is what is represented by the green line, early intervention, and the blue line, late intervention, where the tumor burden never reaches zero. Now, as I said, there is a cell cycle effect. The drugs which are cell cycle specific will act only during those particular parts of cell cycle. When we will talk about the mechanism, individual mechanism of the drugs, we will know which drugs are cell cycle specific and which are non-specific. And then there could be cell-to-cell variation in the protein levels, which can also affect their killing. So basically, from the Gompezian curve and the cell kill theory, one line that you should understand is that there is an inverse relation between cell number and curability. So higher the number of cells, less the chance of curability. Less the number of cells, higher the chance of curability. That means if you intervene and treat the cancer early, you have better chances of cure rather than intervening later and trying to treat the patient. So when the disease is already metastatic, tumor burden is higher, the chances of cure is almost negligible. Now, there are a few examples like choriocarcinoma, Burkitt's lymphoma, where a single drug is very effective. But apart from that, wherever the cancer chemotherapy is used, it is a combination chemotherapy. Combination is always decided. There are certain rules which decide that what two drugs can be combined. So most of the time, the first thing is that the two drugs should be from a two different classes. One thing is that only the drugs which has maximum cell kill when they are used alone are to be combined. Then two drugs from the same class is usually avoided because they can have a large number of interactions and they can have overlapping toxicities. So they should be avoided. And the drug resistance is lesser if we use more than one drug. So in cancer chemotherapy, you have two drugs, which is called doublet. You have three drugs, which are called triplets. And you can also use four drugs combination. So most of the therapy that you are going to see will be two drug combination, three drug combination, or a four drug combination. As I said, the drugs which are effective individually are only to be combined. The drugs which has highest rate when used singly are the best to be combined. And when you are combining two drugs, you should select the drugs which do not have overlapping toxicities. So if you choose two drugs which has the same toxicity, rather like a hepatic or renotoxic drugs, then you are going to produce more toxicity. But if you combine a drug which has a hepatic toxicity with the one which has a renotoxicity, your toxicity profile will go down. And the drug should be used in their optimal dose and optimal schedule. So for each drug, there is an optimal drug and optimal schedule to be used. and you should not arbitrarily reduce either the dosage or the time interval between the therapies. Now, how do you decide that what is the best time interval between two cycles? And this time is basically discovered by looking at the recovery of the normal body cells, and the most sensitive to chemotherapy, as I said, is bone marrow. So you give a chemotherapy, give the optimal time for the bone marrow to recover back to normal before you give a second cycle of chemotherapy. It is important to know biochemical, molecular, pharmacokinetic mechanism and interaction between individual drugs because before you can use them in combination. Otherwise, you end up having more toxicities. If you omit a drug from a combination, what will happen? The cells which were sensitive to that particular drug will overgrow. And then you are going to have two clone of cells. One will be killed, the other one will proliferate. Because a tumor is a multiclonal organ where all the cells are not the same, but each cell is different. So there are multiple clone of cells within a tumor. So I'll come to the first class of chemotherapy, which was discovered first, alkylating agents. Anybody can tell me what is alkylation means? Alkylating agents are the agents which introduced a OH group between the covalent bonds of DNA, and they react with DNA bases and basically cause dysfunction of the DNA or break the double helix DNA. These agents are nitrogen mustards, aziridines and epoxides, alkaline sulfonates like busulfan, nitrosoureas, hydrazine, triazine derivatives. The second class is called cisplatin and its analog. These are the drugs which has a platinum in 2 plus or 4 plus oxidation state, and it is the oxidation status which decides the stereochemistry of the carrier lesions, and this basically acts uh, acts at the N7 position of guanine and adenine residue to form a variety of monofunctional and bifunctional ducts. Drugs are cisplatin, carboplatin, and oxaliplatin. Cisplatin is highly nephrotoxic and hyperemetic, while carboplatin and oxaliplatin are less nephrotoxic and less emetic. The next class of drugs is called antimetabolites. These are the drugs which interfere with the folate metabolism. The first drug is methotrexate, which basically inhibits the dihydrofolate reductase enzyme, and this leads to reduction in the level of folate inside the cells and hinders with the cell cycle. Other antifolates are raltrexate and pemetrexate. Among the antimetabolites, there are some which works on other mechanisms. These are also controlling the level of folate inside the cell, but not directly, but through thymidine. So the drug is like 5-FU of 5-fluoropyrimidines, which causes in the inhibition of thymidine synthetase, which ultimately also leads to deficiency of the folate and modification of methylene tetrahydrofolate inside the cell. And this depletion prevents the tertiary complex formation. Other drugs are capecitabine, which is oral, citarabine, and gemcitabine. 6 thiopurines are there: mercaptopurine and thioguanine, fludarabine, and cladarabine. Then there is a class called topoisomerase interactive agents. Topoisomerase is an enzyme which is required for packaging and unpackaging of the DNA. And these agents basically inhibit the topoisomerase enzyme and interfere with the unpacking of the DNA, which is required before the DNA synthesis takes place. Among these drugs, these are classified as camptothecins, epipodophylotoxins, anthracyclines like doxorubicin, apirubicin, daunorubicin, and valorubicin. The word rubicin in the end includes that they are red-colored compounds. Mitoxantron, dactinomycin. Then there is a class called antimicrotubule agents, inhibitors. Microtubules are basically a 13 linear protofilament of polymerized tubulin heterodimers, which is arranged in the parallel around the cylindrical axis. The microtubule formation occurs in M phase of the cell cycle or the mitotic phase of the cell cycle. So these are the drugs which basically inhibits the microtubule formation and thereby interfere with the cell divisions. Among these are vinca alkaloids like vincristine, vinblastine. These are the compounds which were earlier isolated from the vinca rosaceae family. This is a common flower which exists everywhere. Even in Banaras, you can see this flower. You have texanes, which was originally extracted from Texas brevifolia. Paclitaxel and docetaxel, there are two texanes which are available. Then there are miscellaneous agents which does not have a very specific, where there are no more than one drug which has the same mechanism of action. L-asparaginase, which basically inhibits the L-asparagine aminohydrolase, and this causes reduction in the asparaginase level in the cells and interfere with the survival of the cell. Bleomycin, this is isolated from the culture growth of the fungus. The cytotoxic effect of bleomycin result from formation of oxygen-free radicals. And these free radicals causes single or double-stranded DNA breaks. There is a new class of compounds which are not actually cytotoxic but cytostatic. They are called tyrosine kinase inhibitors. Tyrosine kinase is an enzyme which basically required for the cell cycle to complete. And these compounds, depending upon which of the tyrosine kinase they inhibit, are classified according to, like imatinib is BCR-ABL tyrosine kinase inhibitor. BCR-ABL translocation is seen in CML, and this drug is very effective in all those patients where there is a BCR-ABL translocation. Then there are EGFR TKI tyrosine kinase inhibitors like gefitinib. They inhibit the epidermal growth factor receptor tyrosine kinase pathway and block the EGFR signaling pathways. Other TKIs are erlotinib, which is again EGFR inhibitor, sorafenib, which inhibit BRAF, VEGF, EGFR, and PDGFR. Sunitinib, which is basically PDGFR and VEGF inhibitor. Dasatinib, which basically blocks BCR-ABL. Nilotinib, which is again active against BCR-ABL or c-KIT. Lapatinib, which blocks HER2/neu, and neratinib, which block HER2/neu. Then there are certain miscellaneous agents like bortezomib. Bortezomib basically has a chymotrypsin-like activity and blocks the 26S proteasome in mammalian cells. It is used for treatment of multiple